Yes, ma'am, we are good to go.
Okay.
Okay, great. Hi, friends. Welcome to this session 8 in Innovation in Hematology, which has been spearheaded by our Dr. Nikhil. And as we fondly call him, Nikhil Myeloma Kumar, because he is spearheading our whole program of myeloma and he has given us new dimension in the field of myeloma. And today is a very special day. We have a very, very renowned, well-learned speaker, Dr. Swaminathan Iyer, whom we have developed a friendship over a conference. And that's how these conferences actually helps you to develop fondness and friendships. And gracefully he has accepted our invitation to speak on a very, very dear topic of AITL, because in our last 6-7 months, we have a spades of AITLs which are coming after 3 to 4 lines of therapy for various infections, tuberculosis, or being treated as Hodgkin's lymphoma. They have landed, and Dr. Kunal, who's a brilliant hematopathologist or say lymphoma pathologist now, by virtue of being a friend, he has been able to do that. And of course, Dr. Srinidhi is around here, who's doing the NGS on these samples, FFPs, to understand where we stand. So combining together, it's going to be a very interesting session. We have already sent few questions to Dr. Swaminathan Iyer, and please be ready with your set of questions, which Dr. Nikhil in the end will discuss and Kunal will discuss. We hopefully have Soumya Ranjan also from All India Institute of Medical Sciences joining in shortly, because these are the group of people who will work on AITL in the future. So without taking much of your time, and thanks Dr. Swaminathan Iyer for accepting our invitation. We are humbled with that, and people across 30 countries will be listening to you on the challenges of angioimmunoblastic T-cell lymphoma. Somehow this tends to be happening more in Middle East and in CIS regions, which were the reason which we don't know, but probably after your talk, which will give us a future directions, how to conduct research in this area, which is still an unmet need for the country as such. Over to Dr. Nikhil.
Thank you, Dr. Bhargav, and welcome one and all to this 8th session in the Innovations in Hematology lecture series. So today we'll be discussing regarding angioimmunoblastic T-cell lymphoma. This is one of those diseases where diagnosing this itself is a big challenge. And thanks to Dr. Kunal, we have been picking up quite a few of these patients off late. And surprisingly, like Dr. Bhargav mentioned, before coming to us, they come up with multiple lines of multiple biopsies being reported as reactive, sometimes tubercular, and very often they are diagnosed very late in their disease course. And for delivering the lecture, we have Dr. Swaminathan Iyer, who is a professor in the Department of Lymphoma and Myeloma, Division of Cancer Medicine, University of Texas, MD Anderson Cancer Center, Houston, Texas. He is a world-renowned expert on T-cell lymphomas. He's an internationally recognized expert in T-cell lymphomas, and he leads the T-cell lymphoma program at MD Anderson. He also has a keen laboratory interest in CAR T-cell therapy and machine learning approaches to predict biomarkers from whole slide images. Before we go on, I would also like to introduce a special guest for today, Dr. Kunal Sharma, who's an Associate Director and Head of the Department at the Mumbai Reference Lab, Agilus Diagnostics. Dr. Kunal is well known in the field of hematopathology. He's trained in oncopathology from HCG Cancer Center Hospital, Bangalore. He has numerous publications of high repute in various national as well as international journals. We have been fortunate to collaborate with him on lymphoma pathology, and he has done extensive work on double and triple hit lymphomas. One of the largest from India was presented at the International Leukemia, Lymphoma and Myeloma Congress. He's also the editor with Indian Journal of Surgical Oncology. He is also the recipient of Under 40 Healthcare Award this year, Best Healthcare Innovators in the Under 40 category. So before I go over to Dr. Swaminathan, Dr. Kunal, if you could share your words of wisdom and inaugurate the session.
Sure. Thank you so much, Dr. Nikhil. At the outset, first, I would like to thank you and especially Rahul Bhargav sir, who has been instrumental in getting all the minds and people who are really interested in the field of hematolymphoid malignancies. Also, a warm welcome to Professor Swaminathan Iyer. And I was fortunate to meet you at the Fortis Cancer Summit as well. And I think AITLs, as we are more and more seeing, are one of the most misdiagnosed entities. We've had cases of Hodgkin lymphomas coming to us as AITL. We've had cases of, even some THRL, BCL kind of lymphomas, or other T cell lymphomas, PTCLs, which have been diagnosed as misdiagnosed, and they eventually we see that they happen to be of the T follicular helper immunophenotype. Sometimes even reactive nodes can be very, very, AITL pattern 1 can masquerade like a reactive node also. So AITL is definitely the most, it's like a potpourri, and it's a very hot cake of interest. So without much ado, I would, give the virtual stage to Professor Iyer to share his talk. Thank you.
I'll stop sharing my screen. Before I hand over the stage to Professor Iyer, I would also like to introduce the speaker for our next webinar. This will be on the 18th of October, 7 p.m. to 8 p.m. Indian Standard Time, where Dr. Fadi Haddad would be speaking to us on the choice of second-line TKI in CML patients. So I'll stop sharing my screen. Over to you, Dr. Iyer.
Thank you for this generous introduction. It is very nice to meet you all in person. I enjoyed your session, Dr. Kunal. You had all those googly's of pathological diagnosis, and happy to participate in those. So I'm going to see if I can share the right presentation. Is this the one? Okay, here it is. Okay, so thank you all once again, and it's a great. It's always feels good to be part of the group and to go. If not be in India, I was just in India for 4 days before I went to China, and so always feel homesick when I talk to my colleagues from there. So today's goal is to talk about AITL, but nevertheless. We have to learn about other T cell lymphomas to some extent to learn about AITL and possibly about other lymphomas, as Dr. Kunal said, before we learn about AITL, because it is so variant in its presentation, and it can have lots of different presentations and clinically and also pathologically speaking. But to set a stage, this is the ICC WHO classification, which if you see here, and get my laser pointer working. Okay, here. If all the angioblastic T cell lymphomas are lumped into one group as T follicular helper phenotype. Along with angioblastic T cell lymphoma are the other types which used to be classified in PTCL, and we'll talk about that evolution, which is the nodal PTCL T follicular helper phenotype, based on some of the work done by the French colleagues, and also the follicular T cell lymphoma. I think it's important to recognize that they are biologically very similar entities, and possibly the response to treatment as well. And we still are trying to figure out if they are two different ends of the spectrum. Clinically, for example, going from a TFH type to an angioblastic T cell lymphoma type. And I think it's been recognized by the pathologists, but clinically, we have not made the distinction as yet. Of course, you have the other varieties listed here. Occasionally and very rarely, we do see cutaneous angioblastic T cell lymphoma. We've seen a few patients either as an initial presentation or as a reactive process. Most commonly, it's a reactive process, and I mentioned this. A lot of them do present with skin manifestations and GI manifestations, particularly diarrhea. And we have a manuscript that is still in the works, and I mentioned this, analyzing 250 patients in MD Anderson with cutaneous manifestations. Majority of the time, it's reactive. Very rarely is a skin involved with AITL, but most of the time, it's a reactive dermatitis. And even there's a pattern. If there's a localized involvement, from a prognostic perspective, they do fine. But if it's complete involvement, particularly the trunk and the axial area, they don't do as well as those without the skin manifestations. So that being said, since the focus here is in AITL, I won't spend much time on the others. But just to show, as I mentioned, we can't separate the other T cell lymphomas in terms of clinical perspectives. It's being classified as a mature T cell lymphoma based on the WHO, and now the ICC WHO, and PTCL-NOS. So what used to be called not otherwise specified, which shouldn't be called that anymore. It used to be the largest number of patients in terms of T cell lymphomas. The new diagnosis in the US is about 10,000. About 30 to 40% of all nodal lymphomas used to be NOS, but you can see that once NOS was deciphered, a fraction of those NOS became ALCL. A large chunk of it became a nodal PTCL, a T follicular helper phenotype. And so when you lump the AITL, T follicular helper phenotype, lymphomas are the largest varieties of the T cell lymphomas, nodal. The ALCL, ALK positive and ALK negative, good case presentations and also poster child for drug development. Even though they're not so common, occasionally we do have issues with the ALCL ALK positives and many times with ALK negatives in terms of clinical relapses. But we won't spend much time, but just to learn about how the drug development has happened with the focus on CD30. Obviously, one of the things that we also learned from diffuse large B-cell lymphoma, the other poster child in terms of drug development. The first drug was Rituxan, which improved the prognosis from CHOP to R-CHOP. We don't yet have anything for angioblastic T-cell lymphoma, even though we have something for the ALCLs in terms of what we can do to improve the outcomes. So obviously, T-cell lymphomas are multiple diseases. You already heard from Dr. Kunal in terms of the diagnosis. One thing about T-cell lymphomas, and Dr. Kunal appreciates this as much as I do, and all of us do here, is that it is not a cookie cutter approach to lymphomas. You can't just take a lymphoma, look at it in the microscope, do a bunch of immunohistochemistry and say, this is a T-cell lymphoma. There's so much of pattern recognition. There's so much of making sure that this is not an overlap syndrome, a composite lymphoma, or even a Hodgkin's lymphoma, because sometimes you do see CD30 expressing large cells, which can be mistaken for Reed-Sternberg cells, and it can skew the diagnosis in a completely different direction. So just for Dr. Kunal's sake, I didn't anticipate just have some of the slides from Dr. Elaine Jaffe's group, where they describe this feature of the small to medium-sized cells. And here, the key thing is it's a lymphoid follicle. For those of us who love to learn about lymphoma biology, it's a incompletely formed lymphoid follicle. The lymphoid follicle, if you think about it, has all these follicles, the cortex, the medulla, and then you have in each of the follicles, you have the entry point for the dendritic cells, and then the outset. It's sort of like the barrier, the sentinel cells, and then that's the point of entry and also interaction. That's the border zone, and that's you see here in the B is the dendritic cell meshwork, which is completely disrupted. You also see B cells in that area, and there's for whatever reason the whole apparatus is disrupted, and that's what gives you the clue that this is angioblastic T cell lymphoma. And an extreme situation, I won't spend much time in pathology to show that there is expansion of all these cells around these small to medium-sized cells. And some of these cells are B cells, some of them are plasma cells, some of them are macrophages. And sometimes these B cells, or majority of the time in the AITL manifestations, the B cells are infected with EBV. And the theory here is that you have local immunosuppression that causes the B cells to lose the immunity against the EBV, and they enter the B cells through CD21 and then get infected. Sometimes it gets to the point that sometimes you can't distinguish the B cells which expand and might also have a diffuse large B-cell lymphoma. They're still trying to reconcile how to approach this. It could be a simple B-cell proliferation to a PTLD to a diffuse large B-cell lymphoma in this setting. So these are the three patterns that Dr. Kunal was talking about, where the pattern 1, it's very hard to distinguish from a reactive follicle, to a pattern 3 that is completely effaced, and it's very somewhat easier to make those diagnoses. And clearly the FDC meshwork, the neoplastic cells, and the background, all these things help us make this diagnosis. So obviously in the lymphoma biology, lots of things have happened since the first recognition, culminating in this 2022 edition of the WHO and the ICC, which not only involves morphology, the nuclear contours, the immunophenotype, the molecular type, And now I think we recognize AITL as an entity. And in many situations where there is a doubt, we often end up doing the typical genomic sequencing that is in AITL, which we'll talk about, which is all skewed towards an epigenetic signature that is malformed. So there is a change in treatment paradigm. As I mentioned earlier, ALCL is a poster child. We have not yet peeled off the AITL, but I think we're getting there. The ALCL is CD30-directed therapy. For AITL, I think a lot of drugs work, but I think we have not done the studies the right way that it should for us to say that we have a drug for AITL, at least in the newly diagnosed setting. In the relapsed refractory setting, I'm going to show you that a lot of the new agents which are not yet FDA approved, and even the ones that are FDA approved, have a sensitivity towards AITL. And that's a good thing, but we also have to do the study in the right way and also show you how the studies are done and why they were a failure. Having said that, we have not made advances in T-cell lymphoma, particularly the last approval was in 2018 with brentuximab in combination with CHP in the United States. So we have long ways to go. On the other hand, B-cell lymphoma is galloping ahead with multiple approvals, and we might get the fourth bispecific and the fourth CAR-T approved in diffuse large B-cell lymphoma. So just a slide to show that CHOP has been the default, may not be the case. We use CHOP variations, and I'll show you data that preferably we try to add etoposide to CHOP for our patients with angioblastic T-cell lymphoma. And it's important to consider etoposide for those patients who don't go on studies. And there's also intriguing data that CHOP may work in some patients, but again, it's the vagaries of how studies are done. But I think CHOP is probably not sufficient for the majority of the patients. We really don't know who might benefit from CHOP alone or CHOP plus etoposide or CHOP plus a biologic, which we don't have yet. And I'll show you the failure of romidepsin. And we think that azacitidine could be one of the first drugs that might have a specific approval or at least a pathway for approval in angioblastic T-cell lymphoma. So these are all the attempts that were done in the past for improving upon CHOP. And we'll talk a little bit about romidepsin CHOP and why it was a failure, the combination of romidepsin with CHOP versus CHOP. There was no difference in PFS. There was no difference in overall survival. However, and we will see that there was a response only in the T follicular helper phenotype. The addition of etoposide, we follow this. The old data from Golems, from German study, is that the etoposide clearly seems to help patients, but majority of those patients were ALK positive patients. But nevertheless, we have subsequent data to show that the AITL patients also benefit from this. And we have a recent publication that I'll show you about this. And invariably, the paradigm for T-cell lymphomas, the nodal T-cell lymphomas, is to find the chemosensitivity with the induction approach and then follow it up with an autologous stem cell transplantation. That's been the best outcomes for our patients. The best bang for the buck is upfront for these patients. And I think there's a lot of controversy because of misinformation or also reluctance, and also because of various realistic issues such as age, logistics, etc., why patients cannot get upfront autologous stem cell consolidation, which, if possible, is probably the best long-term approach. And our own experience from MD Anderson, about 293 patients, can see this is Dr. Samir Sroor, who presented this data a few years ago. Upfront stem cell transplantation, you can see the curve, survival curve, as opposed to those patients who don't get a transplant or who relapse. And if when they do get a transplant, it relapse, and the outcomes are very poor. So in other words, you have to try and get the autologous stem cell transplant upfront. There is also this data from Dr. Smith of why we don't do an allo transplant because of the risks of an allo transplant. But yet, for the right patient, if you handpick those patients, maybe there is a reason to do an allo transplant. But at least in the algorithm, we reserve the allogeneic transplantation for those patients who go through the induction, go through an allo, and get to a remission, and then follow that with an allogeneic transplantation. So as a second CR or a third CR, if you will, if they can get to it. Yeah, so we don't normally consider allogeneic transplantation. We've had patients who, we do autologous transplant. Age is not a consideration. Sometimes arbitrarily 65 is a cutoff. in many countries. But here, our oldest patient was 82 years old, who underwent an autologous stem cell transplant for AITL and is still doing well now 8 years later. So stem cell transplantation, as I mentioned, carefully chosen, and we won't discuss this anymore. So CD30 was the first line in the sand that was drawn, and we learned this from ALCL. And this is the Echelon 2 study that allowed patients with T-cell lymphoma, nodal T-cell lymphomas. Initially, it was meant to be an all-comer study, but the European agency said you have to enrich this for ALCL. So 70% of them are ALCL patients, and they're randomized to receiving either BV, CHP, or CHOP. And there was an interim PET4 and the end of treatment PET4. So the PET was done after 4 cycles, not 2 cycles, as we typically do in diffuse large B-cell lymphoma. The primary endpoint was PFS. And a lot of you know this data, so I'm going to run through this. The majority of the diagnosis here is ALCL. But let's focus on PTCL-NOS and AITL in particular, because that's the discussion today. And it met the primary endpoint, which is the PFS. Even at 5 years, there was a reduction in the risk progression and also death for those patients who got A plus CHP compared to CHOP. And so was the overall survival. So this is the only frontline study that has both the PFS and OS advantage in the randomized fashion. So you can clearly say that brentuximab makes a huge difference. And this study allowed patients with other CD30 positive T-cell lymphomas that had at least 10% expression. ALCL is 100% expression. So you don't really say CD30 positive ALCL. But for the PTCL-NOS and AITL, the cutoff was 10%. It was local evaluation, not a central evaluation. But if you look at the PFS for PTCL-NOS and AITL, it is not very different compared to the ALCL. And if you actually look at AITL, interestingly, those patients with CHOP did better than those who received A plus CHP. So what's going on here is a question. But the numbers are very small. You only have about 30 or 24 patients with CHOP and 30 patients with A plus CHP. But the overall survival is not any different between these two groups. On the other hand, if you look at the PET status, which we just recently presented at EHA, those patients who achieved the PET negativity either to CHOP or to A plus CHP had a longer response and durable response, and there was a survival advantage for these patients. Although, remember, this is 70% ALCL, so it is pushed and driven by ALCL. There were AITL patients who, if they managed to get a PET negative status, seem to do well. So so if you think about this, there are about 54 patients with the AITL, and it's not a big number compared to ALCL, which is about 120 patients. So small numbers, and it is just the selection of patients with early diagnosis. And one of the things we have not teased out is that where they fit into the patterns of AITL versus the PTCL follicular phenotype that could have skewed some of these changes. So we then asked the question, what if you enroll patients with CD30 expression less than 10 or even less than 1? And Echelon 2 types approach. And this, again, was a presentation at EHA. And the only thing different was that this is a stratification between less than 1 and less than 10%. And also, this is a central pathology review. And here, the patients enrolled were both PTCL-NOS and AITL and follicular T-cell lymphoma. You can see that there are about 30 patients with this TFH subtype, and they all had advanced features such as IPI and ECOG status. And most of them are younger than 65 years, so they're eligible to get a consolidation and transplantation. And the safety was not any different from Echelon 2, so some peripheral neuropathy and neutropenias. So very similar. But more importantly, if you look at the response rates are very similar. The overall response rate was 74 to 84% when it was rated by the investigators. And when it was rated by the independent review, it was 83% overall and 84% for those less than 10%. And it was lower for those with less than 1%. And it begs the question, what in AITL patients particularly have CD30 expression? I didn't show in the previous slide some of these immunoblasts, and one of the characteristics of AITL is this arborization of these venules along with the FTC meshwork, and then you have these large cells that invariably express CD30. And I'll show you in the other studies, sometimes the CD30 expression in the immunoblast is has CD30, but that's not a tumor expressing CD30. So there is a little bit of confusion, and there's also not the alignment amongst pathologists on what to rule. But when the central pathology review was done, here clearly they highlighted only those patients that had CD30 expression in the malignant T cell population and not in the B cell. So clearly in this case, as you can see, that the response rates are a little lower. We don't have the PFS for this. So we will wait. This probably will have a presentation at EHA just to show that at least for less than 10%, you can use brentuximab, and potentially if the response rates are high, we don't have the PFS as yet. What we did, and this is work from one of our medical students, looked at CD30 expression in angioblastic T-cell lymphoma and about 300 odd patients, and you can see that there are 182 patients who had a CD30 expression. And when we actually looked at the patterns, most of them had advanced stage disease, and the CD30 was detected at the time of relapse. And it sort of makes sense because CD30 is an activation marker. So advanced stage disease, you have a lot of things going on in the microenvironment. And at the time of relapse, you have CD30 expression. So it also gives us, as for clinicians, the opportunity to use BV. But when we looked at brentuximab in terms of survival outcomes, it didn't show any difference, whether they got BV or no BV, or whether they had transplant or no transplant, albeit this is a retrospective review. But I think it's important for us to dig into this a little bit more. One of the things we think why this happened is because CHP BV, as you saw on the previous slides with the less than 1%, we have not quantified this. Secondly, I think the CHP probably is not sufficient for AITL, and we need to go back to adding etoposide, and then we have data to show that. So that's this next study. When we add etoposide with CHEP BV, and consolidate them with stem cell transplant, and also do the maintenance of consolidation with BV up to 10 cycles. And this study just came out in July and Lancet Hematology. You had non-ALCL subtypes. And this study started around the same time that brentuximab was approved, so around 2018, 2019. It was completed just before COVID. So we almost have 5 years, 6 years follow-up data that was published here. And you can see advanced stage disease. What is different is that they got CHP BV plus etoposide day 1, day 2, day 3, and majority of them received consolidation. And if you look at the response rates, 90% response rates. So in other words, we think that for diseases like AITL, where you have BV that may not be as supportive, but when you add etoposide, suddenly it pushes the response rates all the way over the edge. And if you look at the survival curves, on the top you have the overall survival, it's really a flat line. And then this at the bottom, the PFS, you actually see many patients are potentially cured. And we still have patients in the long-term follow-up who are doing well. So in other words, for diseases which are CD30 positive, which are non-ALCL, particularly the AITL, that's the discussion today, I think this is a great approach to follow for our patients, the opportunity to use etoposide along with CHP BV, followed by consolidation, stem cell transplantation, and maintenance with brentuximab. And if you compare this with the echelon 2 that I showed earlier, the PFS seems to flatten out much earlier with this cohort. And we think this apples and oranges comparison, but we think that etoposide clearly adds to brentuximab, which clearly adds to CHP. So in other words, CHOP is not what we should be doing for AITL. So that's my thesis. And if you look at the overall survival, clearly a huge difference for those patients who received the CHP BV compared to the AITL patients who either received CHOP or CHP. So there are a lot of other CD30s, and remains to be seen if it's MMAE, but these are phase 1 studies, so we'll see how it goes. So romidepsin CHOP, a word on why this failed. I think part of the reason is because when the study came about, there was no enrichment like the echelon 2. And the number of patients with the TFH, in retrospect, when the study was started, we didn't know that there was this TFH that could be lumped into one group. So a lot of these patients came with the diagnosis of PTCL. It was a label rather than a descriptive diagnosis that was added on. And so that's part of the reason. So patient selection, even those patients who had AITL, there were about 40 patients in both the groups. And I did some calculations that if you actually increase this by another 30 patients, this could have been a positive study. Why? Because even though the PFS overall was not met, there was clearly advantage for those patients who received received a RO-CHOP in the T follicular helper phenotype. In other words, it's a post-hoc analysis, and the TFH patients did have a PFS advantage by adding romidepsin CHOP. The other reason why this study was negative is because the toxicities were higher when you combine romidepsin and CHOP. So in other words, we could have done this better, but hindsight is always 2020, right? So these are some of our mature T-cell lymphoma pathways. Everybody goes in clinical studies. Now we have two frontline studies. One is a crescendo study that's looking at belinostat and pralatrexate versus CHOP. And we will have other studies, especially the JAK1 inhibitor as a single agent. And so what we're trying to do is line up for the next 5 to 10 years to try and see who needs chemo, who does not need chemo, and use biologics up front and maybe push chemo towards the end. So those are all the things that we are doing. So just a summary of the front line, Echelon 2 clearly shows some benefit for PTCL-NOS, but I think etoposide makes a huge difference based on our investigator-initiated study that is just published. And CD30 expression needs to be is very important, but you have to make sure in AITL that it's only seen in malignant T cells, not in the immunoblasts. But if you look at the situation, most of them relapse, unfortunately, and we only have 4 drugs, including this chitamide in China, and romidepsin is withdrawn from T-cell lymphoma, even though romidepsin is probably the most active agent in AITL. And if you look at the PFS, it's very poor. It's anywhere from 1 to 4 months. And it's not very different from our own experience at MD Anderson that Dr. Dai Chihara presented. The PFS is 2 to 3 months, depending upon if it's PFS1 or PFS2 or PFS3. So how can we harness the advances in biology? And we talked about this pathology where ALCL is somewhat easier. AITL, when it is classic, it's easier, but there's a lot of issues with diagnosis and the NOS, which is not actually not otherwise specified. Now, this is Dr. Javeed Iqbal's and Lawrence DeWalt's work that I've combined when Javeed Iqbal did the study of gene expression profiling and found that PTCL-NOS is not just PTCL-NOS. There were fractions of those patients who actually had AITL. On the right-hand side, you can see how the switch happened from PTCL-NOS to AITL. There's at least 10 to 15% of patients, and those were the PTCL T follicular helper phenotype. Of course, there's also movement towards other diagnoses such as ALCL, ALK negative. There is also extranodal NKT cell and also ATLL. Many times ATLL shows up as PTCL-NOS. And at the bottom, you see the work done by Lawrence Duval and found when she compared the AITL with PTCL unspecified or not otherwise specified, you can see that there's movement across, and a whole bunch of PTCL patients were actually reclassified based on the architecture into T follicular helper phenotype, but PTCL T follicular helper phenotype. So in other words, it's very important, even if it's PTCL, that you are not just dealing with a PTCL that is just non-decrepit, but you need to do the diagnostic studies, particularly the epigenetic pathways. And what is important if it's PTCL-NOS, which is not AITL, there are 3 groups, which is the TH1 type, which is TBX21, or the GATA3 type, which is the red one at the bottom. And why is it important? Because the GATA3 patients don't do so well. So this is a different biology. This is not AITL. This is only in the so-called PTCL-NOS, which doesn't contain the ATLL or the ALCL or the AITL. And that's where I think it's important for us to clearly label the PTCL-NOS properly and also label the AITL properly. So a lot of this goes back to the pathology discussions Dr. Kunal was talking about. At least for the PTCL-NOS, we have pathways based on the Catalina-Amador approach of using TBX21, CXCR3, and GATA3, sort of like the Hans criteria, if you will. We can discuss this later, but just to say that the cell of origin is important in PTCL-NOS. Of course, doing somatic mutations is important. And if you look at AITL, there are mutations in the T cell receptor pathway and the co-stimulatory pathway. More importantly, there are mutations. MD Anderson trying to capture all these mutations by using N lymphoma assays. So I'm trying to I want to combine how the emerging themes in T-cell lymphoma can help AITL. So we talk about epigenetic pathways, some of the dysregulated pathways, and also the CAR-Ts perhaps. So the epigenetic pathways were discovered in the work done by Javeed Iqbal from Nebraska. And when you go back and look at some of these cells that have these epigenetic pathways, they are the T follicle helper phenotype. And they have markers such as PD1, ICOS, CXCL13, BCL6, and CD10. Sort of like a follicular lymphoma T cell counterpart, your B cell to T cell counterpart. And about 50-70% of them have the Rho A mutation. And then you have the, others, or they are mutually exclusive. You can have TET2, DNMT3, or IDH2 mutations, or you can have combinations of TET2 and DNMT3. And why is it important? Because the survival is very different. The DNMT3, just like in MDS and AML, don't have a good outcomes as opposed to TET2, but I think it's also with limited usage of agents that we have. And then you have the IDH2, which actually seems to be about 33%. But we don't really use IDH2 inhibitors in AITL because the population is much smaller than AML. And the first studies, when we went back and looked at our own romidepsin data, we found that the romidepsin actually had a higher response in AITL patients. And the azacitidine that was done in France initially in the single agent also showed a very similar approach. So Dr. Lemonnier and his group did this randomized phase 3 study of comparing oral azacitidine against investigated choice of various agents, whether it is bendamustine or gemcitabine or even romidepsin. And you can see that there were some differences in the cohorts, but this is a negative study. And just like a road chop, this is another learning moment because the endpoint, their expectation was that the oral AZA would meet the endpoint of 12 months PFS. It did not cross 5.6 months. However, what we do learn is that just because we think chemotherapy works in these situations and we want to take them to a autologous stem cell transplantation in the relapse setting, you can see the chemotherapy, the median PFS is only 2.8 months. So it's 3 months. Even in that small, even though it is not powered to answer that question, the investigator's choice was clearly was not as good as this. And it's a lesson for us to learn that in the relapse refractory setting, particularly in the primary refractory setting, you have to use biologics. And this is a thesis against using chemotherapy. Interestingly, there was overall survival difference between AZA and those patients who got the chemotherapy, though that is not the primary endpoint. It is 18.4 months versus 10.3 months. So there's a big difference. And we also know that AZA and ROMI can be combined. There's an ongoing study of combining 5-azacitidine with romidepsin against investigator's choice. This is Owen O'Connor's work, and won't spend much time on it to say that this is something that we are using in the as a off protocol for certain patients. And so the TFH is a second line in the sand that you can draw, and it's an ongoing study of epigenetic markers, at least by stratification, and comparing this with CHOP or CHOEP with the HDAC inhibitor. In this case, it's in this is azacitidine versus CHOP. And this is based on GRU1 study of using AZA plus CHOP, and the response rates are pretty high, about 95%. And what we saw here is that TET2 mutation responses are much higher than DNMT3 mutations, but it's a small cohort from the Cornell group. But we'll see what the largest study shows, and also our own study with belinostat versus pralatrexate in the frontline setting. So we think that epigenetic pathway is a second line in the sand like CD30, which should be used not only for diagnosis, not only to peel out the PTCL NOS from AITL, but also for therapeutic purposes, because you can then preferentially use either a AZA or a HDAC inhibitor. And I'm just going to quickly go through some of these other dysregulated pathways. Ruxolitinib can be used in AITL. In this case, the study that was done clearly found that phospho-STAT1 is a biomarker for those responses is seen in this Cornell study. And this is the spatial information that is provided using phospho-STAT. Now, there is another JAK inhibitor called golidocitinib, which is published. We were the only non-Asian site that participated in the US. And this is a JAK1 inhibitor. Golidocitinib is 150 milligrams per day. And you can see that most of these patients had PTCL NOS and AITL, again, not subclassified. and the responses were about 40% with CRs of 23%. I'm going to show you those three different agents, but in all these things, you have a 40% overall response rate and 20% CR, which is much better than some of the other biologics like romidepsin. It's double the responses, double the CRs. And the safety is also very good in this golidocitinib. PI3 kinase pathways struggled because of the class effects and also a lot of side effects. But what we do know is the GATA3 positive T cell lymphoma and a lot of angioblastic T cell lymphomas use this PI3K hub. So how do you come up with a better PI3 kinase inhibitor? This limperlisib is the latest in class. And the reason why it's different is it's renally excreted and does not cause colitis, as you will see. And this is data from Dr. Song at ASH presentation showing responses of about 48% and 30% CR. And this is the swimmer's plot with a lot of greens. And if you look at the responses, the best responses are in angioblastic T cell lymphoma. CRs of 50%, overall response rate of 65% compared to the other subtypes. And the safety, most importantly, you do not see immune-related events such as transaminitis or colitis. And so we did this study in US and also Europe, and we will be presenting this data at ASH. This is a good example of a patient with angioblastic T cell lymphoma who got CHP-BV and had primary refractory disease. So we didn't choose the chemotherapy pathway, got limperlisib, and immediately after 2 cycles goes into CR, and after 10 months continues to remain in CR and then is consolidated with the transplantation. Valemetostat is an EZH1, EZH2 inhibitor, and similar subset of patients that are included AITL and nodal PTCL with TFH phenotype. The responses were very similar in the 43% overall response rate, and this is the PFS and overall survival. So there are multiple randomized studies in the relapsed refractory setting that are ongoing looking at valemetostat, limperlisib, and also with golidocitinib. And just to show you that we are making progress, we have moved from a 15 to 20% response to a 50% response rate with these agents. A few words about the microenvironment and where we think the checkpoint can fit based on our own investigator-initiated study. We already mentioned that AITL has a lot of rich cells around it, macrophages, the B cells, the plasma cells, and whatnot. And we exploited this by combining romidepsin with pembrolizumab, an investigator-initiated study, wherein we used romidepsin day 1 and day 8, and then pembrolizumab every 3 weeks with the primary endpoint of safety initially and then overall response rate. Clearly, there were about 38 patients, and about half of them were nodal TFH or PTCL. And cycle 6 response was 71%. The best response was about 50%. And so these are approved agents. But if you look at the PFS clearly benefited the TFH patients and the overall survival compared to even PTCL and OS. These are clearly separated out. We took out all the ones that were not TFH. And so we are doing spatial transcriptomics and whole exome sequencing, and we'll present this data at ASH this year just to show that we think that there's another opportunity other than AZA and ROMI is to use checkpoint inhibitor for TFH type of T cell lymphomas. And these are some of the targeted genomics. We don't see a pattern as yet, but what we do see is a response. The other subtype that also benefits is ALCL. This is a patient with BI-ALCL, which essentially manifested as ALCL, the breast implant-associated lymphoma, and received multiple chemotherapies, had a very cytokine-rich disease, and after combining pembrolizumab with romidepsin, went on to achieve a complete response. So we think that the AITL is right for the combinations, right for biologics, and I think after a point when they relapse, chemotherapy should not be used in the future. It's going to go into a combination of biologics, but it's probably going to take the next 5 years to find those answers. Finally, cytokine storm is AITL is a lot of cytokines in it because of hyperactivation of T cells and macrophages. One of the things we have done is to look at what makes a difference, the lack of a biologic, but we also try to improve this extreme cytokine storm, which is HLH with an OHI index. Dr. Abhi Maiti also had a presentation DIHA, a late-breaking abstract of using a pan-SERP inhibitor. Many of these patients are T-cell lymphoma, including angioblastic T-cell lymphoma patients. Not only it's early data, but clearly it prevented them from dying, with the mortality rate is pretty high in the first 60 days. But it also was able to get them through the lymphoma. There were 2 or 3 patients with AITL who actually had, without receiving other therapies, had response to the underlying disease as well. So it remains to be seen. Last word on the CAR-T. CAR-T is a struggle in T-cell lymphoma because of fratricide with the common antigens used, but we think the post-thymic antigens are ripe, such as the CD30, CD37, CCR4, and CD70. There are problems with the CD30 studies, mainly for the manufacturing, if you will. We think the CD70 is a good marker. CD70, like CD30, is seen in activated cells, such as some certain Tregs and certain memory T cells. The expression is pretty high, including angioblastic T-cell lymphoma. And so we did a study by using this CRISPR-Cas9 allo CAR from a donor. And this is the summary slide to show that off-the-shelf CAR-T and initial data on 18 patients. Happy to let you know that just a few days ago, our manuscript was accepted in Lancet Oncology. So you'll see the updated data on 54 patients, and many of the subtypes and the response rates in the 70%. And the final response in the 54 patients was about 50% with just one allo therapy. And you can see responses in multiple compartments. And this is not AITL, but just to show you, this is mycosis fungoides, which is transformed. And this patient received brentuximab and relapsed. And then when the patient received allo CAR, and there's complete resolution within 7 days, and then went into almost a CR except for this fibular lesion. And this is another patient with transformed MF, where oozing wounds, and 30 days later, everything is healed magically, and you can see that the PET became a CR. So I think what we're doing right now for AITL and all the subtypes is to better understand the biology. T-cell lymphoma is not one disease, it's multiple diseases. Just as ALCL was moved up in terms of its prognosis and outcomes, I think AITL is the next disease because we have all these different agents and immunotherapies that can make a difference. So it all falls on the pathologist, for you, Dr. Kunal Sharma, to enable us to get the best possible diagnosis, and possibly not just a morphologic diagnosis, but also the cytokines and the cell of origin, so that we can have the right treatment options for our patients. So for the newly diagnosed, use the induction transplant approach, if possible, maintenance, and for the relapsed patients, try and get them to biologics. So that's the theme of the presentation. And just want to show you that we have a moonshot program at MD Anderson. We're third year in terms of funding. And one of the questions we're asking is, what's the role of B cells in the T-cell lymphoma, particularly in angioblastic T-cell lymphoma? So stay tuned. I just want to show you that it takes a village, an Olympic village, to get us through this multiple diagnosis of T-cell lymphomas, and also a lot of information, which is the path forward. And thank you. Happy to answer any questions.
Thank you, Dr. Iyer. That was an excellent presentation. You have comprehensively covered the topic and also touched upon all the recent advances in T-cell lymphoma management. We have collected a few questions from our Indian colleagues as well as the audience. Can we go ahead with the question answer session?
Yes, please. Certainly.
Yeah. So the first one, I mean, as a clinician, this is a very basic question that I would want to ask. Why is it that AITLs are very often mistaken for a reactive lymph node? And are there any soft pointers when it comes to the pathology? Probably Dr. Kunal can also pitch in here. Are there any soft pointers when it comes to distinguishing a reactive node from an AITL?
So a lot of it, I would leave it to the pathologist, but it's finally some of these early diagnoses are clinical pathologic, and there are situations. So clinical situation is important. We have had patients who take methotrexate for other reasons, may end up having some kind of a reactive process where helper cells are more, and may even have adenopathy. I had a patient who had a anti-epileptic change from Keppra to phenytoin, and the presence with the lymphadenopathy, and then found to have TFH. Now, these are not these are not malignant clones. Of course, I'm talking about in days before we started doing NGS. the clinical picture is very important. And now at least we have the NGS to fall back on. You have to look at the clonality. We don't talk about clonal hematopoiesis. A lot of these AITL patients have clonal hematopoiesis, which the TET2 and DNM3 represent. So even if you do the NGS, sometimes whether it is really a reactive process with clonal hematopoiesis, so you're sort of getting into the weeds in this early processes. So clinically, what you do is if it's early disease and you have the right clinical context, you sometimes watch and see 3 months later what happens to these nodes. For example, in this patient with phenytoin, we stopped the phenytoin, the lymphadenopathy went away, and we avoided using chemotherapy for these patients. And same thing with methotrexate. So I think the clinical context is very important as much as the descriptive studies that are done by pathologists. Dr. Kunal.
Right. From the pathological point of view, first of all, I would just like to say that Dr. Iyer, your talk was fantabulous, and I think it was very crisp, and it explained and touched upon all the points, not just from a clinical perspective, but even at the pathological perspective. And it is important to understand the pathogenesis to really figure out why AITLs behave differently. From the pathological perspective, as Dr. Iyer had also mentioned, and I had also mentioned, there are three patterns in AITL. There is the pattern 1, which simulates a reactive node. Then there is a pattern 2, in which these reactive follicles, they start to regress a little. And then there is pattern 3, in which you usually have a diffuse lymphoid infiltration. So the most difficult to differentiate from a reactive node is the pattern 1. But there are very subtle cues which help you differentiating, because in AITL, the mantle zones will not be well cuffed. They will have a bit of an obscuring. The second thing is that in these areas, you will have on IHC, you will have these T cells which will express the T follicular helper immunophenotype. You have very specific markers for T follicular helper cells. You have CD10, BCL6, ICOS, PD1, CXCL13. So these are the markers. And once you see that in the obscured mantle zones, these kind of markers are being expressed, you know that you are dealing with a case of angioimmunoblastic T cell lymphoma.
And Dr. Iyer, you mentioned about all the upcoming treatments for AITL, and many of them, like JAK inhibitors, would be based on a NGS. So, do you do a tissue NGS for all your patients with AITL at baseline? And
Yeah, we
does it
try
help you to modulate your treatment either at diagnosis or at relapse?
So we try to, we've sort of in a data collection mode. Don't think we are at a point to say that we are using this information, but definitely when it comes to trying to find predominant epigenetic pathways, we try and avoid chemotherapy, as I said, and try and go about using agents such as the HDAC inhibitors and azacitidine in combinations if they're not on protocol. Right now, it's all in data collection mode. We also need to have a collaborative study. So, even MD Anderson sees, so we see about 250 patients with T-cell lymphomas. It's not a lot. It seems like a lot. Most people don't see more than, 1 or 2 a year in practice. So we have to collaborate. So all our studies are collaborative. I think in the future, we'll probably have more sorting out the diagnosis based on the underlying pathways. But what is clear is that you should do it at every relapse, at least in the relapse refractory setting, because some of these pathways might change, or the allele frequency might change. You might have one clone dominating over the other. So whereas JAK inhibitor might stop working, but the PI3 kinase pathway downstream can work. So I think you need to ensure that you always have the updated information.
And Dr. Kunal, considering the therapeutic options we have when it comes to a relapse setting, what are the markers that you would be keen to look at when you get a relapsed AITL case, either from a IHC perspective or from an NGS?
So, from an IHC perspective, we would first like to confirm that it is the relapse of an AITL and it is not something else. A very pertinent point which was brought out by Dr. Iyer was of the B cells, which are very, very of peculiar interest, in an AITL setting, because these are EBV infected, and many a times in concurrent settings or in relapse settings, you actually are dealing with a EBV positive DLBCL. In a patient who was previously diagnosed as an AITL. So you have to be very, very careful with what you're dealing with. From the NGS perspective, IDH2 172R is the most specific for AITL. There are others, which are also found. There are other genetic and epigenetic modifications which are found, like TET and others, but they are more commoner for other, T follicular helper lymphomas. But IDH2 172R is the most specific for AITL. So that is something that you have to look at. Also, a very, very important thing I would like to share with everyone, that in AITL, the polymorphous, the background is polymorphous. And we have already spoken about these B cells, the EBV infected B cells. These are actually known as forbidden B cells because they're immunodeficient. And you can see clonalities, monoclonal proliferations of these as well. Another very important thing is that sometimes the plasma cell population is phenomenal. And while most of the times it is polyclonal, sometimes it can be monoclonal, and that those are very easily misdiagnosed as probably, a plasma cell neoplasm. So these kind of genetic alterations, when you're dealing with a molecular evaluation, are also seen in a case of AIT.
And Dr. Iyer, you mentioned about the cutoff of CD30, as though conventionally we consider 10% cutoff. But if a patient has, let's say, 5% CD30 expression, would you still treat these patients with brentuximab upfront?
Yeah, so non-ALCLs, right? So I think for AITL, I think we should still consider using brentuximab, but I think our own data and bias is that that etoposide might be needed. And if you look at that, even there is, there's only a small number of patients in the echelon 2, a small number of patients in the CHEP-BV. We think that if somebody has bulky disease, has advanced features, or even dysproteinemia, as Dr. Kunal mentioned, sometimes they also present with MGUS, and it might look like a myeloma. Smoldering myeloma. So I think these patients probably would probably benefit from the chemotherapy. I think that's the initial bias. If you have early stage disease, who are not very symptomatic, and perhaps those patients, you can avoid using etoposide. But clearly the cutoff all the way up to 1%, I think you should be able to use brentuximab.
So it is
mind you, in
1%.
AIT, you'll have to make sure that these CD30 is in the malignant cell and not in the immunoblast.
So it is 1% that is a cutoff that you would recommend, like in an AITL patient, as far as using.
I mean, data-driven approach, yes. This is our data, so it's still evolving. The response rate seems to be a little lower. I think the PFS will let us know if that holds. So again, based on this data, my early read on this is 10 to 1%. I think you could use the brentuximab.
And since many of these patients would have visited multiple centers, and they usually present to us in late stages with bulky disease. So our current practice has been, if they are CD30 positive, we use BVCHP, otherwise we use CHOP with etoposide. But I mean, going back to the data that you presented, do you think a combination of BVCHEP, including
Yes.
etoposide as well as brentuximab in the upfront setting, would make a lot more sense for these patients, obviously followed up by a transplant?
Correct. I mean, so those are the kinds of patients who I think will benefit from the combination, because brentuximab probably adds some. It's probably better than vincristine, but it's very hard to say from a small data set. But I think you saw our own retrospective review. They're all patients who received CHP-BV, not CHEP-BV. So clearly, I think you need to add something else in addition to etoposide. In addition to brentuximab. So etoposide is the most logical approach. So you're sort of blending CHOEP with CHP-BV to come up with this regimen. I think there's a question in the chat.
Yeah, I'll just read it out for you. So Dr. Srinidhi wants to know, what is the role of spatial transcriptomics when it comes to AIT?
Yeah, so I think it's very important. When we do NGS, a lot of them are bulk sequencing, or even the exome sequencing, because we just extract DNA and or RNA, and then we do the mutation analysis or the transcriptome. But we don't know where they're coming from. So sometimes we have algorithms which helps you to reconstruct this. And it's much better if you have each and every single cell in the pathology. Then obviously it gets to the technical aspects of trying to get live tissues and analyzing them. So in lieu of that, how can you take a slide, FFPE slide, and you have the information, you have the spatial information. So how can you get the transcriptome there? So there are many methods available to look for transcriptome. 10x has one, and the nanostring is another approach where you actually have oligos for different DNAs that can fuse to these cells in situ. So, and you can and they all have different colors to it. And so they all have different expression levels. So that is a very popular and also tissue preserving approach for trying to find out the expression of different genes in different cells, especially for AITL, because it's so rich in microenvironment that you don't know where the signals are coming from. You can have mutations in the tumor, but your mutations alone do not give you the answer, and the biologics may not always work because you have a microenvironment that also decides how the biologics work or don't work, right? So I think you need to have that information. So that's the role of spatial transcriptomics. And I think it's an upcoming area. And AITL, I think, is primed, and you'll see our data with the whole exome sequencing and codex at ASH this year.
So we have been having quite a few AITL patients off late, and many of them with difficult scenarios. So would like to discuss a few of them with you.
Sure.
How do you treat an elderly AITL patient unfit for chemotherapy, CD30 negative? What would be your treatment of choice upfront?
Upfront. So we do have data, and I showed you the pembro-romi approach, where you use a HDAC inhibitor with azacitidine. I don't know if romidepsin is available in India.
It's not.
It is not, right? So what we do sometimes is to use AZA, just like you treat these patients with leukemia. The Owen O'Connor had about 5 or 7 patients in this study of 20 patients, newly diagnosed, where combined AZA with romidepsin, and they all went into CR. And I've seen a couple of those patients. So I think that's an approach to take. The other approach to take is, since you don't get romidepsin, you get Keytruda. And this is all, of course, this is all off protocol. This is all semi-data driven, extrapolating information, is to combine AZA with checkpoint inhibitor. Because if you think about it, what AZA and romidepsin do is that they enhance class 1, class 2 expression, improve the antigen presentation. So it's picked up by the immune cells, but the immune cells are not active. So you want to activate the T cells. And so use checkpoint inhibitor. And just a word of caution about using checkpoint inhibitor in T-cell lymphoma. There's always this concern for hyperprogression. But I think in T-cell lymphoma, in AITL, you don't see that. You might see some consolidation of the lymph nodes and the trafficking of the T cells, but typically you don't see hyperprogression. You see that in cytotoxic CD8 positive T-cell lymphomas and ATLLs, not in AITL. So I think if you were to use checkpoint inhibitor has to be combined with this either AZA or romidepsin. So that's another approach to take. You do have Jakafi, right? So these are all off-protocol approaches. So we have also off-protocol combined AZA with Jakafi, which I think would be germane in India. So these are some of the biologic approaches which are well tolerated. It's sort of like your AML, where you've gone from 7+3 to using AZA plus venetoclax. And by the way, venetoclax doesn't work in T-cell lymphomas only because of the pathways of BCL2 are not relevant with venetoclax. We have occasional patients with ALCL and maybe certain types of cutaneous lymphomas that respond to venetoclax. So in lieu of that, I think trying to use Jakafi plus AZA would be a better approach.
That's a very interesting thought. So we have been using azacitidine for these patients who are unfit for any other treatment. But before we give them Jakavi or pembrolizumab, do we need to look at the expression? Do we need to look at the JAK2 or the PD-1 expression, or it can be given regardless?
So what we do know from Jakafi is that the responses are better with phosphostat. So if the phosphorylation of stat is a marker. In the combination, it's not very clear. I think the study that is done by Steve Horowitz, where they actually sequentially added Jakafi and dualisib, which is a PI3 kinase inhibitor, they saw a synergy in those patients who had the phosphostat. You could do it. It's an immunohistochemistry test that can be done. You can also look for the JAK pathway mutations, but I don't think as yet there is a correlation with the mutations, because you also have a whole bunch of patients where the pathways are upregulated and not mutated. So you won't know that by doing any testing. You sort of have to use this empirically. So either you can do the mutations by NGS, you can also do the phosphostat, but there's also the empiric approach.
So it can be used regardless. And how do you use interim PET in your treatment approach? Do you do an interim PET after 4 cycles for all patients? And if they are PET positive, let's say they are receiving CHOP with etoposide and they are PET positive, how do you modify your treatment after 4 cycles?
Yeah, so this is actionable. This is based on Echelon 2 data. The PET positive patients don't have good outcomes. Of course, there's also nuances there. The PET is also not the best test for T-cell lymphoma because there's a lot of inflammation in the microenvironment, and sometimes you have to clarify that the positive PET is actually positive by biopsy. If the positivity is only on the PET, but the biopsy shows some kind of inflammatory process, it's a false positive PET scan. The second is that you have PET positivity in some areas and more than the others, so you could approach them very differently. So if somebody has not had a response, PET is positive, I think you need to change the therapy, and you could declare this as a primary refractory disease and use biologics. So one of the approaches, as we just talked, is to use AZA, move to an AZA. We've had multiple examples where we have used AZA with romidepsin. And of course, it doesn't apply to you, but we've changed the schedule from Owen O'Connor's schedule. And we have many patients who actually have gone into complete remission just by using this combination, with the PET positivity at either cycle 4 or cycle 6.
So AZA with romidepsin would be a good combination for such patients.
Correct.
We have a 48-year-old AITL, again CD30 negative, CHOP with etoposide, went into CR, transplanted, but unfortunately relapsed within 3 months.
Okay.
A frank relapse. So again, how would you approach these patients? Would it be
And
still?
is it a bulky relapse?
It's a bulky relapse. It's a bulky relapse. Extensive bulky relapse with extranodal involvement. And currently the performance status of the patient is not great. ECOG PS3. So
because of the disease. So
because of the disease, absolutely.
So AITL, if it's AITL, I think they can have a cytokine storm. Is there cytopenia?
Yeah, he's progressively becoming cytopenic.
And we have confirmed that there is no other disease and there's no HLH.
Yeah, we have confirmed. We have done a marrow. We have also done a repeat lymph node biopsy, which Dr. Kunal has seen and is confirmed to be AITL. No HLH as of now, but cytopenia because of disease involvement.
The reason I say is that that scenario, the bone marrow may not show hemophagocytosis, and you don't need hemophagocytosis for lymphoma-associated HLH. You just need elevation of ferritin, and the value of ferritin, the threshold is 1,000, but you can use 2,400, and IL-2 soluble receptor at 3,900 international units. So when you have these two, that's the OHI, optimized hematologic inflammatory index. That's good enough to make a diagnosis. And why that is important is because you can use chemo, but for the most part, you have to take a long-term biologic therapy approach. So if you use chemo, you're using it to debulk. And since the patient already received etoposide, let's assume that this patient has HLH, then I think you'd use a gemcitabine-based approach and potentially use agents such as anakinra and Jakafi. Patient does not have high ferritin, does not have high IL-2 soluble receptor. You can still use gemcitabine-based approach like GDP to debulk and then quickly go to the non-chemo approaches, because as you saw from the Oracle study, these chemo responses don't last for more than a few months. And this, I suppose, from the very nature of this patient's disease, it was deemed to be chemorefractory. Also would go ahead and look for CD30 expression in this particular patient, because sometimes you do have CD30 expression at the time of relapse. We have used bendamustine BV. So it's sort of between using biologics and between using the gemcitabine-based approach. And if the patient does not have HLH or at least has a tendency towards this, I think you can still use Benda-BV. There is data from the French group showing that it actually works, and they would use 70 milligram per meter square because the counts are low, and use BV, or even start with sequential BV first and then followed by bendamustine.
Okay.
If
So
CD30 is
the
positive.
idea would be to debulk the disease and then go on to biologicals. So
Correct.
GDP, and if there is an HLH, gemcitabine, Jakavi, these agents would definitely
Correct.
help the patient.
We have a case series of combining gem with the Jakafi. Gem-Ox is the regimen that we've used. You have to look for cytopenia. So practically, when you use Gem-Ox, you have to make sure that that Jakafi is stopped for the nadir points, because there's drops in counts, there's thrombocytopenia,
Right.
and we use the ruxolitinib at 10 milligrams as opposed to 20 milligrams BID.
Great. Fantastic. I mean, that is something which I think we should try and eventually go on as azacitidine. And if the patient does achieve a CR and patient has a donor, do you consider for an allo-SCT?
Absolutely. I think for the right age, right performance status, I think allo is probably the best approach to take. In refractory disease for AITL, the outcomes are not very good. I think if you can get the patient to a CR, and if the CR is durable at least for 4 to 6 weeks, I think that's probably the best approach to take.
And our AITL patients, PTCL, and in general, T-cell lymphomas have not been doing very well with an auto transplant. So considering the data you presented, do you think if we have a targetable mutation like CD30, all of them should go on a brentuximab maintenance post-transplant?
Yeah, that's another approach to take, again, small number of patients. The problem, though, is that when patients get either vincristine or brentuximab upfront, they don't tolerate post-transplant brentuximab. And as was also seen in Hodgkin's lymphoma, the Athera study was done in patients who did not receive prior brentuximab. So, all of them got a year's worth of maintenance.
Right.
But in real world setting, most patients get brentuximab and they don't tolerate. So I think if you can practically or realistically consider even 4 treatments of brentuximab, I think that's probably sufficient.
And you have been doing a lot of work on artificial intelligence, AI-based models. So do you think such a model would be practical for AITL patients where
Absolutely.
baseline characteristics which could actually predict who would do well and who may not do as well with the conventional treatments we used?
Yeah, so so you saw my last slide is more about each patient has big data, right? So I think you need to have all data. And one of the good things about using approaches like machine learning and deep learning is that you can look at multiple variables. When you have small number of patients, you use conventional statistics, and you're always looking at that p-value and then univariate, multivariate analysis, which is sort of hand crafted events. And you look at the traditional approaches of IPI, LDH, performance status. They're all very important, but there are a lot of variables that we don't know of that are going to help. And those variables lie in the complexity of pathology, the spatial geographic information, the complexity of genomics. But then you have to get that information, you have to get the pathology information, you have to get the clinical information, you have to put them all together. And the only way you can actually do something is by using machine learning, deep learning approaches. And you need a deep learning approach to actually take data, to datafy images into variables that can be used for analysis. So
Right.
I think AITL is probably the prime time. You'll see our presentation at ASH. It's a prime time to do these kinds of analysis, because it's not just the disease. Hodgkin's is another case in point, where you have a few tumor cells, you have a lot of reactive cells around, and there's already some effort on spatial transcriptomics there. So I think lymphoma is a prime time to do these kinds of analysis.
And question from Dr. Anusha. Many of the AITL patients present with autoimmune manifestations, joint pain, skin rash, and that's probably true for most T-cell lymphomas. First, why is it that there is an increased predilection for autoimmune manifestations in these patients? And second, would you treat them differently? Or is it the AITL standard treatment that you would approach?
That's a great question. I think part of it is what we had discussed earlier. There is this reactive processes, the plasma cells and the B cells that also get activated in this process. And then you have a lot of autoimmune phenomenon, not very different from what we see with CLL and marginal zone lymphoma. So that's one of the reasons. And the second is it's bathed in a lot of if I'm use the right word is rioting. So when you have cells and you have other cells gathering, you actually have a ganging up of all these lymph cells, and there's a riot, and you have a cytokine storm that happens. So for all these reasons, patients have symptoms. You have TNF alpha, you have IL-6, and all these things that present in the manifestation of fever, joint pain, skin rash, and then autoimmune phenomenon because of B cell proliferation. So in those patients, at least for the B cell autoimmune process, it's very reasonable to use Rituxan. So, and Rituxan is used for these processes. Rituxan can also be used when you have this extreme B cell proliferation and you have EBV that goes into lytic phase. So that's another dynamic event that happens that we don't really evaluate. We actually have a manuscript on evaluating EBV in the setting of T cell lymphomas. And AITL is very different because it's only seen in B cells. All of the T cell lymphomas, you see them in T cells. So you have EBV proliferation, and it's B cell. So in this case, Rituxan is actually applicable. You can use 1 or 2 doses of Rituxan, especially when the EBV copy numbers are more than 10,000. So in those patients, you treat them very differently by adding Rituxan. There is also the other enigmatic process on how the B cells coordinate with the T cells and or support the T cell. And there was actually a French study looking at Rituxan with CHOP, irrespective of whether they had autoimmune phenomenon or not. And it is a negative study, but I suspect that the number of patients are not sufficient. So in those patients, treat them differently, use Rituxan, and that's probably sufficient. We've also had patients, I should add, who had concomitant diffuse large B cell or PTLD, B cell PTLD with AITL, and those patients have done well with addition of Rituxan. So that's a variation to keep in mind because AITL is not one disease.
We discussed about the role of maintenance brentuximab post-transplant. In patients who have completed treatment and who have achieved a CR and not fit for a transplant, would you consider them also for a brentuximab maintenance if they cannot undergo an auto transplant?
Yes. So this study that we did, the CHEPBV, allowed us to, rather, the patient who had the ability to choose to go undergo a transplant or not. There were about 8 to 10 patients who did not undergo a stem cell transplant and had the brentuximab maintenance. Many of them were ALCL patients. There's only 1 or 2 patients with AITL and PTCL NOS. So potentially that is a possibility for those patients who cannot undergo a transplant. But do we have data? It's a small number. It's just, the study was about 52 patients, and then you have a small number in that. There is data to say that you can do it, but whether it helps, I think I would pay more attention to the biology, why they're not tolerating chemo. Is brentuximab, it's sort of halfway between a biologic and a chemotherapy. Should we actually move towards a long-term biologic? So these are things to consider.
I think we have come to the end of all questions. We have covered the questions from the audience also. Dr. Kunal, anything from your side? If you
it was great to see Professor Iyer once again, and it was such a comprehensive discussion on all aspects. Just wanted to add one thing, which I feel is very, very important in this in the pathology of AITL, is the follicular dendritic cell meshwork. To all the pathologists and to all those people who get a little confused, if you are seeing expansion of your regular follicular dendritic cell meshwork, that is a very, very important cue that you might be dealing with AITL, and that also helps us in. You had asked me this previous question about a reactive lymph node versus AITL. So the expansion of FDC meshwork is very, very pathognomic for an angiomyoblastic T-cell lymphoma. But I would just like to sum it up by thanking you, Dr. Nikhil, especially Dr. Rahul Bhargav and Professor Swaminathan Iyer for such engaging discussions, and bringing light to this really, really deceptive entity of angiomyoblastic T-cell lymphoma. Thank you.
Thank you,
Thank you,
Dr.
Dr. Kunal, for joining in and providing your valuable inputs. Dr. Iyer, it was a pleasure interacting with you over the last 45 minutes. You have covered such a complex topic, which is confusing for pathologists and clinicians alike. AITL, right from the diagnosis to the management and following of these patients, is always an enigma. You have covered it so comprehensively and you have answered all our questions patiently. So many of the difficult clinical scenarios we face, I think we can handle better with collaboration as well as the use of novel molecules, especially in those who are not fit for intensive treatment. Thank you so much, Dr. Iyer.
Thank you very much, Dr. Nikhil. And again, as I said, you kept me in line, and it's so important to have this conversation. And thanks to Dr. Rahul Bhargav, I think his enthusiasm and passion for bringing new therapies in hematological malignancies and other tumor types, I think is phenomenal. Dr. Kunal, I think it's so important to have you as the foundational support for this program, and I'm so impressed with the presentations and your telepath sign outs. So I think I would offer this, since we are foraging in an area that I think you have all the data, like a lot of people do, is in pathology. Would be very happy to collaborate with you and build this ground up in terms of using or developing pathology as variable, pathology as data, beyond the label, if you will. And I think that can be a force to come, and we would want to see that what you're doing in the clinical realm also translates into the research realm. And I would be very proud to have you do those presentations at ASH. I think we need more of those.
Thank you so much. Thank you, Prof. Thank you so much. Been an absolute pleasure and enriching experience to interact with you again. Thank you.
Thank you.
Thank you, Dr. Iyer. We have more than 250 people joining in from 10 different countries. I'm very sure everyone who has joined in today has greatly benefited from this lecture, and we have all been enriched, and hopefully this will go a long way in managing our T-cell lymphoma patients better. We hope to collaborate with you more in the future, and as always, discuss our difficult patients with you. Thank you so much for sparing your time on a Friday morning and joining us for this academic session. Thank you, Dr. Iyer.
Thank you, Dr. Nikhil. Thank you. Have a good evening, all of you. Thank you.
Thank you.
Good evening to all. Thank you.
And before we wind up, I would also like to thank Emcure Pharmaceuticals for providing this platform for holding our academic webinars. It has been very smooth, and it has been a pleasure to coordinate with you for all our academic events. I thank Emcure Pharmaceuticals also. And before we wind up, I thank each and every one of you who has joined in this Friday evening, sparing your time to attend the academic session. I hope this has been useful, and we'll join in next month with our webinar on CML with Dr. Fadi Haddad on the 17th of August. Thank you all, and goodbye.
Thank you. Bye.